Well, good afternoon, everyone, and welcome to this symposium on the fantastic new technology that was introduced a couple of years ago, and that's the Silk Symposium. I have with me Dr. Rohit Shetty, who will be joining in a little while. Uh, we have Dr. Chow Kai Chang, and can we have the panelists also? Dr. Rajiv Chaudhary and Ajay for this session. Uh, Dr. Rajiv Chaudhary, as you all know, he is a very proficient cataract and refractive surgeon and out of Indore, and he has a couple of other centers. He's really doing a grand work. Ajay, as you all know, is the founder of the IQ group of hospitals, starting out of Gurgaon, and I think they are across about 15, 18, I don't know, Ajay, 18 cities? Sorry? Okay, so I was right. And could you?
I come from Taiwan. We
He's
have
from Taiwan, yeah.
30 eye clinics.
30.
30.
30,
30.
good.
30.
Good. So Rajiv, you are the one who has to catch up.
Lowest center.
Okay, doesn't matter. Anyway, great for everyone to be here. Taiwan, I am sure, does the maximum one of the largest refractive surgery practices that they have. So we'll start with the talks, and maybe I think I have the first talk,
Yeah,
and that will be yeah.
Maipal is having the first shock. My journey with Elita, please.
ठीक है it'll be a bit yes ma'am audio is better than Lapiada but Lapiada probably
Well, good afternoon again, and I'll be talking about my journey with Elita. I think I was fortunate enough to be associated with the development of the Elita right from the beginning. And I think 2018, and then during COVID stuck, and it was a real difficult time, but I think we worked through it, and we brought the platform Elita to fruition. When you look at the lenticule extraction, or I would rather say the refractive laser vision correction platforms, so there are been the thought process of being working on the cornea to be able to actually get rid of refractive errors, and this thought was published first by Lan in the refractive surgery way back in 1896. Sato performed RK from inside the cornea, and obviously that had a lot of corneal edema and things like that. And then you have Barakar. He was actually the first person who came out with the idea of keratomileusis, that means to reshape the cornea from within. And I think there was the ALK that was launched subsequently. Theo Seiler was the person who did the first PTK, wherein the excimer laser was used, and then you have Margaret MacDonald working on non-sighted eyes, and then Palikaris. He was the first person to actually make a flap in the cornea to get what is known as LASIK. And then there have been further additions, etc. And Sikendo and Dr. Rupal Shah then subsequently in India performed the first smile procedures which were there. So that was the onset of the lenticule extraction. And when you look at this, we have the smile procedure, which was born in 2007, and that was, I still vividly remember, it was in the American Academy of Ophthalmology, where it was said that maybe by just taking out a lenticule without an excimer, you could get refractive corrections. Was really something that I was surprised that, well, this can happen. But then things have developed along, and the Elita machine, all safe. Then the Elita machine, basically in 2018, that is when the first laser was fired for the first time on the Elita. That was on the clinical, and obviously we started with the flap, and this is the first flap that is being done in the year 2018. And thereon, once the flap was perfected, the proof of concept of the laser working was there, that we looked at performing the first silk procedure on 4th of January 2020. And so some people ask that it's a new procedure when patients come. So I said, well, we have an experience of more than 5 years now, and I'll be just talking about a couple of results. So this was the first procedure that was performed in 2020. Now, in 2023, because there are now 4 or 5 companies that have the lenticular extraction, the nomenclature today from the individual names, like you have Silk or Smile or you have Clear, etc., has been changed to what is known as Kalex. So Kalex is the name that is there, and that stands for keratorefractive lenticule extraction. That means any type of machine that you are taking working on, and if you are removing a lenticule to get refractive correction, that is called as Kalex. Now, when we started the ELITA, it was called as Cheetah, and that was the study name, Cheetah being the fastest animal on earth. So this was the fastest laser that was there, that was developed. So the project was called Cheetah, and then subsequently it is called as ELITA, and the lenticule procedure, as one would say, smooth as silk. So that is the silk procedure which is there. Now, when you're looking at the ELITA procedure, it's basically designed for a flapless refractive correction for lenticule removal. As of now, it is available for myopia and astigmatism, which is there. The biggest advantage of this laser is that it delivers extremely low energy treatment, which is there. And the pulses are ultra short pulses, ultra fast pulse frequency, and it has a very small spot size. What this does is that it creates fast and smooth cuts. The biggest other advantage that is there is that the lenticule is a biconvex lenticule. There is no other lenticule that is a biconvex lenticule, and there is minimal tissue disruption in the stroma which is there. Now, when you compared the ELITA with the IFS, that was their interlace, you could see that the femtosecond or the time duration that is there is extremely brief, and that is 100 to 200 femtoseconds as compared to the interlace, which was 600 to 800. The pulse frequency obviously has to be much faster. The spot size is much smaller. It is smaller than all competitors, and it is only about 1.3 microns. So the typical example is if you have small spots, you can cut finer, and therefore the outcomes are likely to translate to better outcomes. The wavelength obviously being the same, but importance here is you have the pulse duration being very short, and therefore spot size also being less, and therefore the quantum of energy that is released on the cornea is very low. Obviously, if you are having low quantum of energy going into the cornea, the outcomes of the clarity of the cornea and the quickness of the visual recovery is going to be more. If you just compare the Visumax, the IFS, and the ELITA, you can see this comes as a sharp energy but comes for a very short time. Now, the important thing here is that there is no line and there is no spot separation, which I think may be the future that we could have it, but there is zero spot separation, and what it means is that the dissection that you can do is very easy. You don't really have to struggle, and the incidence of retained lenticle extraction is extremely low. This is just a small little thought process or an experiment that was done, that if you have to rip a paper apart, and if you have thick spots with separation and you have 1 micron spots or lower spots, you can see the ease with which the separation, or you are tearing the paper. So that's something which is easy that you can get, and that is the basic concept. Have small spots with no spot or line separation and make it work fast so that you are able to get good dissection. Now, this next generation lenticular procedure, which is a biconvex lenticule, the indications are up to a maximum of -12, and that is the add of the sphere and the cylinder, but individually you can go up to -12. So if there is no cylinder, you can go up to -12 sphere, or you can go up to a -6 cyl that is there, but the sum of the sphere and the cylinder as is available today is 12. The total treatment time for an optic zone about 6.2 would be about 16 seconds of laser time, and as you all know, when you're doing a lenticular extraction as compared to an excimer, there is no difference in the time whether I am treating a 1 diopter or I am treating a 10 diopters, because it's just the depth that is going to vary, and it's not in an excimer. The time taken is going to be proportional to the refractive error that you are correcting. Now, just as a look, as you can see from the multiple platforms that are available, Vizumax 500, 800, Zemer, and AIOS, and the ELITA, Johnson Johnson ELITA system, wavelength being approximately the same. But what is very important in all these is that this is the repetition rate, and you can see this is the fastest laser which is there. The quantum of the energy, as told to you earlier, is about the least. The laser cut time is significantly less. The only machine which can outrun it today, because it has larger spot size, is the Vizumax 800. The patient interface is flat in Zemer as also in ELITA. Cyclotorsion compensation and centration system, these were two fallacies in the earlier lenticular system which was there. Here you have them. Soon they will be automated, but as of now you have to mark. But right from the beginning, the importance of having a centration, being able to change the centration after docking and to do a cyclotorsion compensation is there. Lenticular geometry, you have the lenticular side cut which is there. This is the docking. Those who have done the intralays can see that this is the docking, and you can mark the center of the cornea, and you can mark the, like you mark for a toric IOL, you can mark the axis for the cyclotorsion compensation. You press on the foot switch, get a vacuum. As the vacuum comes, you can see that you are going into the green area. As you go into the green area, you press, you pinch, and you get a full applanation. And we prefer to keep it in the upper half of the green part, so that there isn't too much of compression. And this is the picture that you get, which is the cyclotorsion compensation that you can see, a 3-degree cyclotorsion compensation. There is centration which is there, and then you press on the foot switch. So this is for those who haven't seen the procedure. So this was, I think, 16.1 seconds or something. This is the posterior part of the lenticule, that means the undersurface of the lenticule. Then you had the round cut. This is the top surface, and this is the entry cut which you have. I normally prefer to keep a 3 millimeters entry cut. You can go down up to 2. This is how the picture looks, and it gets released automatically. Now, this is the patient interface which is there. This ensures easy docking and proper suction. The difference between this and the interlays is that there is no syringe-induced suction. The suction is actually going through the machine, and you can see that it is maintained at a steady state which you have. There is a flat applanation chord. Now, you could actually center the lenticule. You can mark it. You ask the patient to look into a microscope light. The microscope doesn't come as part of the machine. You can center it, and if you want to do a centration, you can easily work on it. Now, this is what you get at the end of the procedure. The only thing here is that because it's a biconvex lenticule, you have to go a little up, and then you go to the posterior plane. Once you have, I normally use a blunt dissector because the ease of dissection is very great. You don't need to have anything sharp. I really always use a blunt dissector, and you can see that this works pretty well. As you go on to the upper surface, then you go on to the lower surface. As you can see, normally it doesn't really, some people have a hesitation, okay, if I go into the wrong plane, what is going to be the problem? It's not difficult at all. Even if you've gone to the wrong plane, you can ascertain the other plane very easily subsequently. And you can see the ease with which we were able to actually do a dissection or the separation. And majority of the people can put it as no dissection. Initial people who are doing should spread the lenticule to see that the lenticule is complete. By far, the incidence of incomplete lenticule is very little, and that's pretty much the end of the surgery. Now, the patient selection for the initial cases, as we looked at, the target patients were -6 and up to -2. That was the correction that we were having. Initially, we looked at patients who were amblyopic. That means that they didn't have good vision, and we worked on them. These are the normal patient selection criteria. So the first phase that we did was on non-sighted or partially sighted eyes or amblyopic eyes, and then we went on to work with the rest. And then I think welcome Dr. Rohit. He's joined. Then Dr. Rohit Shetty was the second site where we had, and then there were 2 more sites, and that is where we looked at. So this study design actually has the combination of data from our center as also from NN, and these were the 2 sites, both in India. Again, it's always for proud moment for Indians, for us to be actually being at the cutting edge of technology and doing these trials. Open label, bilateral lenticle removal. It was a single arm. These were the normal criteria that you had. 170 treated eyes. We looked at the mean pre-op and post-op MRSC, uncorrected visual acuity, and the best corrected visual acuity. Now, when you're looking at these 170, right from the beginning, you could see that the results were very much bang on. We had tight results which were there. Uncorrected visual acuity, 20/20 or better as the time elapsed. Initially, if the vision wasn't like at 20/20, it used to tend to get better. There was no case in which we lost the best corrected vision in these cases. And within plus minus 0.5 of emetropia was in 94% of the cases. Now, what we found was that there was a slight undercorrection when we were looking at, specifically for higher powers. This is the scatterogram that you are looking at. So there has been a nomogram adjustment which has happened, in which there is a slight increase in the power that we do, that is the minus 0.25 plus a small percentage of the refractive correction that you have, both for the sphere and the cylinder. And you can see the tightness of the results, that this scatterogram, you had more patients coming here, you can see that they are within the standard deviation that we are getting. Now, important thing that we noticed right from the beginning was the ease and smoothness of the lenticle removal, and 91% of the cases required little or no dissection. So that is what you saw in the video, that there was hardly any cold spots or areas where you had a problem. This is how we, after every eye that we did, we were supposed to say as to whether the dissection was no dissection, mild dissection, moderate dissection. And this is the figures that you have, that mild dissection was required in 86% of the cases. This is what we got. And the clear corneas were seen at day 1. Vision recovery was really good. This paper has been published in the Clinical Ophthalmology. This is the full text that has been published. So far, I think it has had over 1,500 reads which are there. And this is what I would wish to say is our half-decade outcomes. We have crossed 5 years now, since January of 2020. And 60 eyes of 30 patients, pre-op minus 4.19, post-op is, you can see, 0.2. Contrast sensitivity is fantastic. As you look at the half a decade, the contrast is fantastic. No incidence or nothing much as regards the dry eye. The Shermer's was pretty good. And within half a diopter of emetropia, 90% of the eyes, and 1 diopter of emetropia, 95% of the eyes. So these are our personal outcomes. So this is something that I'll wish to say, that this is subject 1, that the first lenticle that was removed, and this is April Fool's Day, 1 day before Trump announced his tariffs. So, so this is what we have. What have we done is that the energy we have reduced significantly. So there are 3 things that we have done. One is that we always wet the cornea or slightly lubricate the cornea before we applanate. The second thing that we have is that we have reduced the energy. So the posterior energy, which was 60 nanojoules, is what I am using today is 34 nanojoules. They had blocked it at 40. We were at 40 for long, and now the code has been broken for us to use. So we use 34. Anterior energy from 70 is down to 30. And the ring energy from 65 is down to 31. And entry energy from 65 is down to 33. What does it translate to? It translates to cleaner corneas the next day. It translates to more patients coming to 20/20 the next day. Less the energy you use, the better. So what is done in the lab, or what is done is an attempt or it was a question, no dissection. I think that was something which was the focus, that it should be an easy dissection. But what you can see is that the dissection is still remains significantly same, if not better. The next thing that I will wish to have is that I want a line or a spot separation to reduce the energy further. So I hope that will be the next phase that we will be talking about. And this is what is on the horizon. A single piece patient interface work is going on in US. Line and spot spacing is something that I am pushing them for. In the lab, we have done hyperopia and mixed astigmatism. And tomorrow, obviously, once these things are done, we can look at wavefront guided lenticule extraction, which could be the next gen in the refractive correction. So this has been our journey so far in the development of Alita. And with this, I think I would personally wish to say that it has been an exciting journey. Whenever somebody is associated with the development of a new technology, it really is thrilling, and has been a wonderful journey in us getting to these results. And there are so many people here, so there has been a lot of units. I think in India you have done about 25,000 eyes, right? So that's a good number since it was commercially available, and we hope that the numbers will grow. Thank you very much for your kind attention. Thank you.
Okay, thanks for the Mahipo's very wonderful talk. So next speaker, I would like to introduce the Dr. Rohit Shetty. And he is my good friend and also my mentor in Silk. And his talk is about the impact of the nerve regeneration in wound healing post-LASIK. Okay, let's welcome.
Thank you, Dr. Chang. Let me play my slides, please. So, Dr. Maipal sir has made our job much easy by covering up the entire aspects of silk and how the journey of silk has moved from a very, very hesitant stage when we both were very hesitant new surgeons during COVID to what we are today. I've been part of the J&J's journey with silk for the last 5 years now. So before we go into the whole concept about nerve regeneration or nerve tracking, we have to have a brief understanding about corneal nerves and health and disease. I don't need to explain this whole, the structure, the anatomical structure of the nerves, but what is very important is the corneal nerves are very closely related to the epithelium, and each of these corneal nerves here have one branch which has into every epithelial cells. The corneal nerves and epithelium are like oligodendrocytes in the nervous system. That means your corneal nerves have a covering, because we don't have myelin, because these coverings are from the epithelial cells. This has a huge impact in the hemostasis between a corneal nerve and an epithelium, which becomes a very integral part of the healing process in any refractive procedures. If you're looking at the three dynamics, the corneal nerves, the corneal epithelium, and ocular surface cells, apart from the energies, apart from the skill, apart from all the beautiful technologies we have been offered to, what really drives your quality of life is these three fundamental factors. This is how a corneal nerve is. This is how a corneal nerve relates to epithelium. But corneal nerves also are linked to the keratocytes, which is the very important factors in your wow, especially when you're looking at a refractive surgery. Why? Because these keratocytes play a tremendously important role in the health of your eye and also helps in healing. So if your nerves are linked both to the superior structures and also linked to every keratocyte cells, which needs to secrete a collagen, which needs to secrete healing, which needs to bring out a change in your myofibroblasts. This is an interesting paper which talks about it. When the nerve fibers are cut by refractive surgery or lasers, what happens is you activate the keratocytes, And these keratocytes are driven by factors called the TGF-beta, the same factors which causes the corneal dystrophies, the same factors which causes your changes in your trabeculectomy, multiple things. And these myofibroblasts needs to heal faster because the nerves had to bring in a lot of growth factors which has to change how the myofibroblasts change. These are all very fundamental uh, ways of how cornea healing happens. And why do we need all this is because we need to understand if you can do anything by minimizing the amount of nerve damage, we might actually make epithelium to heal faster, and we might actually help the corneal keratocytes to become less aggressive. So we use confocal microscopy to study a lot of these things, and this is how confocal microscopies look: the epithelium, the corneal nerves, the keratocytes, and endothelium. We also use a beautiful software by Sysmetrics. It's an offline software to look at corneal nerves, the corneal branchings, the corneal length, and every aspect. This was designed by endocrinologist from he was Pakistani but works in Oman, and this is such a beautiful thing because he used to work on diabetic retinopathies and how this diabetic retinopathy have an impact on the corneal nerves. So he was kind enough to give us his software, so we use this a lot in our analysis. So let's look at nerve tracking in laser versus non-lenticle procedures. We know how it works. What we believe is the profile and both the energies, the precision of your laser spots, the low energies, both have an impact in the corneal nerve. This is a research question we need to ask. When we looked at the LASIK, we all know about how the nerve cuts are, but the same thing, if you see the ELITA here, the nerves hardly show any changes. In fact, we might see some amount of branching, which is normally how it heals. But when we look at other lenticule procedures, you see that all procedures will damage corneal nerves. It's not that it will not damage corneal nerves. Silk also changes corneal nerves. It's all about relative, whether it does more or less. You can see that the recovery is much faster, much quicker. And we did some analysis. I just showed you some of those analysis. We did analysis. Silk also drops down, but the drop and recovery was very fast. And you can see that most of those factors match, and this is on the lenticule. With other CLEX procedures, you can have multiple things, but we have not compared every one of them, but at least some of them which have a similar profile. So it significantly better pattern observed with silk. Now, when we look at nerves, the first thing which comes to mind is dry eye. Dry eye is not the only one which is driven by the nerves, because if you look at a corneal nerves here, this is what a traditional cornea of a patient coming to you who's been contact lens wearer, and this is what happens. He is contact lens intolerant, high dry eye. Molecularly, he has a lot of these factors here. We call it as dendritic cells, antigen presenting cells, and T lymphocytes, which are all floating out here. If you have 10 patients, you will have 10 of them with this contact lens and all these things having the same picture. And you do a procedure, and you're already working on a very angry keratocytes, the bright keratocytes which are angry, and you do a procedure on them, your corneal nerves heal completely differently. That means a healthy cornea heals faster, but when you have a LASIK here, if you have a more inflamed eye, for example, your cornea nerves hardly heals even after 9 months. But here in silk, even with an inflamed eye, it's not as great as a healthy eye, but it's still healing. So what's beautiful here is, in today's 2025, your people are working for long hours, you are exposed to a lot of toxic light, you're exposed to environment. Your corneal nerve healing is not the same as a normal versus an ocular surface immune changed eyes. So what is important is every biology is different. And the most important thing for me is not dry eye. Most important thing is how the cornea remodels. Because entire aspect of healing is driven by how the epithelium remodels. For example, if your epithelium is not remodeling well, it can induce multiple changes. This again the same picture. Remember this nerves. Nerves have an impact on the nerves, on the epithelium and the keratocytes. And you can get this heaped up epithelium, which is very commonly seen after any refractive surgery like LASIK and other procedures. And what happens is, look at the healthy ones and unhealthy nerves, and because those are all epithelial cells, which are breathing epithelial cells, real ones, with those messengers out there. And these are dry cells, dry eye, epithelial cells with dry eye. And you look at this, what happens to them is completely different. Let's go back to the same nerves. A healthy nerves make the epithelium to heal better. And you can see that all the greens here means we all know that pre and post was good. Just 2 months back, I started using a new technology, very, very innovative technology company called AIOS. They have their booth here with Tosh Bro. They do a ray tracing of every layer of your eyes. We all have ray tracing by InnoVise, but that's one big model, but it's like every level. I'm so fascinated by optics and biology that whenever new things comes, I always try to put and go and try to understand. And this is an epithelial ray tracing, stromal and everything. So that means you know that I'm working on how the epithelium is remodeling. Very interesting thing, this was a patient referred to me from Chandigarh, post-smile, and he's written a lot of blogs about being very unhappy. And he says that he's so unhappy that he says that people should never get this kind of procedures. I'm not sure whether it was one of the CLEX procedures. I don't remember exactly. I didn't bother also. But what you really see is that this is a ray tracing of the epithelial map. That means it refractives part of the epithelium, which shows that he's refractively ray tracing is showing a diopter of refraction compared to the just outside the pupil. And what is important is, this is when I started looking at more and more of LASIK and non-proper healing epithelial maps, you see a lot of ray tracing happening, which we were never able to pick up, because most of the time epithelial maps comes like this. It doesn't give you thickness map, is not refractive maps. But when you start comparing the real thing, then I told him, your problem is in the epithelium. It's not the surgeon I've never seen such a beautiful surgery. I told him, I would be so happy. I don't know who surgeon is, but it's one of the best smile surgery. You can't even make out anything. But your problem is you're healed in such a way that it is causing you problems. And then I said that the only way down is that you can do a ray tracing epithelial topo-guided treatment. That means you can knock out only those irregular epithelium without knocking up the stroma. And then we started looking at, me and Pooja started looking at what kind of smile, Silk, AIOS, Zimmer, what are they doing? And also the Wavelight Plus on the epithelium. And what's interesting here is, when it creates least amount of changes on ray tracing, you mean you reach the perfection of healing. Because that is what is important. And this is, look at different refractive procedures. Look at the amount of refractive changes it's causing on the epithelium. This is something very new data, and I'm working on it, but I feel the quality of your wow is tremendously dependent on quality of your epithelium, and that depends heavily on the quality of nerves. And this is a few cases I've done. Beautifully, it looks at all the maps out here, and this is self-explanatory. We need to look at the immune profiling, and this is what we work on, which will be commercially available by January. Now I can openly, proudly say that. And this is the same patient, the gentleman from Chandigarh. Look at this. This is his epithelium, which is irregular, and the same patient's nerve has not regenerated at all. He has got two small nerves, which ends with a small microneuroma filled with T lymphocytes and a few dendritic antigen presenting cells. And look at this, biomarkers are very high. Classic sign of inflammation because of nerve regeneration leading to epithelial remodeling and patient being unhappy. Now, I don't want to do a PRK on him, because if you do a PRK, he will end up, even if I do a PRK of 0 microns, he'll end up in a haze, because T lymphocyte secretes TNF-alphas, and that caused haze. So I had to give him at least 3 months of levotigrust because that is works on there is a combination handshake here happening between T lymphocytes and the dendritic cells. This handshake releases the factors, and that factor is what causes the haze. So we need to take care of that. And this is what happens when there's high inflammation, the WOW, less WOW, when you have a lot of edemas out there. And this is when you have a healthy ocular surface, you can see that there's no change in your biomarkers and reports at all. I'll just take a minute on this because you have patients coming to you with symptoms. Nerves are not just for dry eye. Nerves are for nociception. If all of you sitting here are comfortable, that means your nociceptive factors are perfect. But we checked this nociceptive score. That means how much are you intolerant to things which should not be intolerant to. For example, sunlight, AC, somebody speaking loudly, or just cold water. What we found was the silk surgery had the least amount of nociception. I'm not looking at dry eye. Let's forget about dry eye. I don't tell my patients I'm getting less dry eye. What I tell them is, I'm getting you factors which bothers you. If I link this one, your quality of life drops down significantly, whether you do cataract or refractive surgery, when you have a higher level of nociception. That means the quality of life is not driven by dry eye. It's a wrong word to use. It's the nociceptive factors. And what drives the nociceptive factors? Every epithelial cells have these channels. These channels are the ones which are responsible for the state of well-being where you are comfortable. And this is a beautiful picture drawn by one of my fellows, which talks about the pathway. This happens at every single epithelial cell of yours. And what's important is when you preserve these cells, when you don't disturb them, when the nerve healing is better, when your TPR measurement is better, that's what brings you relief when you put cold water into your eyes. That's when you get the perfect thing. And this is exactly the work we have been doing. So to summarize, corneal nerve preservation is not dry eye only. It's all about the complete well-being. It's about nociception. That is what we need to address to our patient. Silk is definitely a nerve sparing. Mechanism of it is challenging to whether it's the energy or it's the shape. It's a big debate. Nociception, good nociception is quality of life. Epithelial remodeling is probably the most important thing what I give Silk today, because that is what makes your quality of vision to change. Thank you.
Thank you very much, Rohit. Always a pleasure listening to you and learning new things. Come, Rohit. Anyway, so he's somebody who really brought science into ophthalmology. We were all clinicians. He's the scientist, PhD guy, and getting others to do PhD. Naren, his brother, has also got a PhD now. Anyway, thanks. I think we started late, and I don't know how we'll finish, but if the time can be squeezed by the other people a little bit. We have next again a bright ophthalmologist, Rushad, trained at NN, and basically 4th generation of ophthalmologist. I hope I'm right, not the 5th.
No, fourth, sir.
Yeah, so they have really, I think, his parents and his father and his chacha and then his grandfather, they're big name to really reckon with, and one of the most trusted people in the eye care business of this part of the world. So Rushad is going to be talking about the silk route, the ocular surface and abrasion post-surgery. Over to you, Rushad.
Thank you, sir. So I'll try to also keep it a little brief because we are running short of time. So I'm going to be talking on the ocular surface and aberrations, our results with the silk platform. And what were the initial issues with lenticle surgeries? One was the caveat was that there was a slower visual recovery. This was due to various reasons. There could have been suboptimal laser energy delivery. Tissue manipulation used to be more Bowman's membrane microdistortions that we had published on. Centration was not very good. You had unwanted aberrations. You had decentered treatments, decrease in visual acuity. Because of this, you would have difficulty treating higher astigmatism in these patients. Another thing was LASIK surgeons were not well versed with lenticule at that time, and it required greater technical skill, a steeper learning curve, and the whole thought was, if we can get this done more easily, why are we going through all this trouble? Toric alignment was also an issue initially with the older platforms, and of course things like dry eye, transient worsening of these symptoms. Now the ELITA, like Professor Mahipal has already mentioned, it's essentially a low energy treatment with a small spot size with contiguous spots. So what we found is that the dissection on the whole, and that's the key point in this, it's an easier dissection. It has a biconvex shape where the anterior and posterior surfaces are well matched, and the Bowman's distortions are minimized by this. There's also, as Dr. Shetty showed, less effect on the corneal nerves, and they're better preserved in this procedure. So we wanted to see what happens to our visual outcomes, quality of vision, and the ocular surface in this procedure. We looked at about 105 eyes. We did the dry eye evaluation, in which we looked at Schirmer's, non-contact TBUT. With the keratograph, we looked at LipiView, the lipid layer thickness, and the OSDI questionnaire. We also looked at thermography, which is thermal profiling of the ocular surface. We looked at aberrations on the eye trace system, and we of course did our usual follow-up on the uncorrected and corrected visual acuities following the surgery. The standard inclusion and exclusion criteria were used. We treated up to an astigmatism of 2 diopters and a residual stromal bed thickness of keeping more than 300 microns. We excluded people with tear film abnormalities, anyone outside the range, any kind of retinal disorders, collagen vascular diseases, etc. Now, what is thermography? Because it's a newer concept that we've been working on. It is actually to look at the stability of the ocular surface. This is the device, which you can see, that small handy device in the top right screen over there. And it actually allows us to look at dynamic blinks and how those affect the ocular surface temperature. And we found that this correlates with symptomatology in dry eye patients, in computer users as well. So we looked at this specifically with regard to flap and flapless procedures as well. So coming to our results, we looked at efficacy and safety data. And what we found was that 95% of these eyes were 20/20 or better at 1 month. No patients lost 2 or more lines of visual acuity. One eye had a suction loss. That was a patient who moved the head quite a lot. So the main thing to remember is that the incidence of suction loss with this device, because of the tighter suction and the better suction that it maintains on the eye surface, is very, very low. And subsequently, we haven't had any other suction loss. There was one patient with a larger dark spot, had a lot more meibomian secretions, which had got plugged onto the patient interface, and no retained lenticule fragments were seen at the point of the study. Now, the accuracy of the MRSC, you can see the spherical equivalent attempted versus achieved. As Dr. Mahipal also mentioned, initially with the initial nomogram, there was a little bit of undercorrection, which was taken care of in the subsequent iterations. And the achieved spherical equivalent refractive accuracy within a 0.5 diopter was 81%, and within a diopter was 93%. This is all data from the autorefractometer, so there could be a little bit of a drawback due to that, but overall the visual acuities were very well maintained. Regarding astigmatic correction, again, it did well. Within a diopter of the intended treated astigmatism, we had 97% of eyes, and within a half a diopter, we had 75% of eyes. Now, looking at the wow effect of the platform, what we found was that including our initial eyes, which was our learning curve, there was a pretty good and a quick visual recovery on day 1. You had a logmar of 0.1 on day 1, and on 0.7 on day 7 that was well maintained. When we actually excluded the eyes, the initial learning curve eyes, that dropped down almost to 0. That means a 6/6 kind of vision on day 1 in 82% of eyes. So basically what we want to highlight with these slides is that the learning curve is reasonably quick in terms of ease of dissection, and therefore then the results tend to become better, faster in this. Now, another concept we've been looking at is optical zones. We looked at both flap and flapless procedures with regard to the optical zones. And the next few slides, I'm just going to highlight what actually happens in refractive, and especially in silk, versus a LASIK treatment of a similar dioptric range. So you can see this is about a 4.25 with a 1 diopter cylinder. the effective optical zone, which is calculated by subtracting on the tangential map on the pentacam, you get this zone where there's less than a 0.5 change in the dioptric power and the tangential curvature. When we measured the horizontal and the vertical diameter, we had about 5.58 and 5.96. So the intended optical zone in this patient was 6 mm, you got about 5.77, which is a very good effective optical zone. For a similar spherical treatment in silk, which we did about a 5.75, we found a horizontal diameter of 5.66 and a vertical diameter of 5.21, still showing a very good effective optical zone of about 5.3. When you come to LASIK of similar treatments, what happens is that the effective optical zone tends to drop down. On average, you can see it's under 5 millimeters in these eyes. And that is an area where I feel lenticle extraction does score over LASIK for that particular region. Specifically with the silk platform, we've been getting pretty good maintenance of the effective optical zone. So why is it smaller in LASIK? There are various factors. There's biomechanics, wound healing, changes in curvature. There's loss of laser energy in the periphery in LASIK, which does not happen in lenticule platforms. The intrastromal ablation, there's more energy delivery, more inflammation, and therefore you can have, because of the inflammation, you can have the effective optical zone becoming smaller. Because this is a low energy treatment, specifically the silk platform is a low energy treatment, because of that you're mitigating the inflammatory effect and the stromal remodeling is less, and therefore you have a better maintenance of the effective optical zone. So this is our data on aberrations from the eye trace system. You can see post-operatively, spherical aberration does tend to decrease a little bit, and that is encouraging because generally you see aberrometry showing increases. Most of the aberrations did not show any significant change. The modulation transfer function, which is a function of our contrast, it did dip a little bit, but it was still above the cutoff of 40% at 10 cycles per degree. So it's showing that it's a well-maintained modulation transfer function or contrast activity as well. And these are graphs just representing our aberration profile. This is an actual example that we've taken from the eye trace, and you can see that there's a reduction in aberrations in this particular eye. This is again what I was talking about with regard to the MTF and the contrast. It stays reasonably well preserved, and you can see it's not dropping under that red box, which means that it's maintaining contrast reasonably well. Now looking at our dry eye data, we saw that the OSDI scoring did not show any significant change. The Schirmers did not show any significant change. Non-contact EBUT did not show any significant change. The lipid layer actually seemed to improve a bit. That is a little counterintuitive, but again, no decrease in the lipid layer. In terms of the thermography profile, we saw that the severity, compactness, and convexity of the ocular surface thermal profile did not show any change, meaning that silk does well in terms of maintaining dry eye parameters very well after the surgery. And this is again just a comparison showing what is happening to the thermal profile over a period of time in LASIK and silk, and showing that it basically does not change very much in the silk arm. So what we knew was that lenticule extraction procedures are safe and effective. However, learning curve and surgical challenges led to hesitation in adoption of the techniques. Issues with centration, toric alignment, older lenticule platforms did cause issues. With the ELITA platform, we found safe and effective treatment for myopia and myopic astigmatism. The recovery is reasonably fast with a reasonably good wow effect. There's a high degree of accuracy, minimal changes in aberrations and contrast sensitivity, and a minimal impact on the ocular surface. We have also published this paper, which is to try and help surgeons improve their learning curve. This is talking about the bubble sign which you get in the anterior plane. So if you're on the right plane of dissection, that bubble tends to collapse. So this is an intraoperative sign to guide whether you've inadvertently gone into the wrong plane, and therefore you can take corrective measures before you actually end up dissecting the entire posterior plane. So I would encourage you to read that paper if you can. It's freely available on the American Journal of Ophthalmology Case Reports website. And a big thank you to all our team at Shroff Eye Center, Dr. Apurva, Dr. Palak, who have been our fellows, Dr. Daryl, Dr. Ritu, and the entire cornea department at Shroff Eye Center. Thank you.
Thanks, Rushad. Excellent.
Okay, the next speaker will be Dr. Rahi, okay, the topic is optimizing laser energy to perfection in ELITA.
Well, one thing which Rushad has actually brought out very eloquently, I've always been a great supporter for the lenticule. 6 millimeter lenticule is a 6 millimeter lenticule, and when you're doing an excimer, it really translates to a lower zone. That's one of the reasons why the quality of vision is better. Yeah, thanks.
So, a very good morning to all of you. I'll be talking about how to optimize the laser energy to perfection. You see, there is a reason why this technology is called silk, because it lives up to the name. The dissection is virtually slipping your instruments through the interface. Why do we need to optimize energy? Of course, we want better quality dissections. The better the dissections, the higher the chances of getting post-op 6x6 vision, better visibility, and lower chances of any tissue remnants or retained. So, I want to show you an example that how beautifully the energy can be optimized and you can get silky smooth dissections in this technology. So this is one of the examples where we could optimize the energy beautifully, and you can just see that I've just entered the anterior plane and the posterior part has already started coming off. And you go into the anterior plane and just look at this now. How smoothly the instrument is slipping. But this kind of dissections can only be achieved if the energies are optimized. So that is the real crux of the technology. So when we are optimizing the energy, it is a delicate balancing art. You see, if your energy is on the higher side, you will get OBLs, opaque bubble layers. And if the energy is on the lower side, you would get dark spots. OBLs can still be managed. When you have an OBL, the dissection becomes difficult. The post-op chances of getting 6x6 reduces, but the final outcome is still the same. But in case you have a dark spot, that is a surgeon's nightmare because you have to abort the procedure. So optimizing energy is a delicate balancing art where you are looking for a sweet spot where you are getting a uniform bubble layer. How do you optimize this energy? Of course, the Johnson & Johnson teams helps you with it, but with time, you can yourself fine-tune the energy, what works best in your hands. So the whole process, it starts with something called as GBT. GBT stands for glass burn threshold. This is the minimum energy which is able to put an etch on the glass surface. So when this etching comes, the engineers from J&J with a table, they give you the initial baseline settings. And from that baseline settings, the fine tuning or balancing of the energy optimization starts. So in my machine, when we started off, the GBT was 30. And accordingly, the energies were set. But when we started fine tuning it, this is the final point where we reached. So posterior, anterior, ring and entry, what we are using is 42, 40, 41 and 41 nanojoules. This image, just an idea that if the energy is on the higher side, you get an opaque layer, and if the energy is on the lower side, you get dark spots. Now, when your energy is on the higher side, you have to start reducing it step by step. So you can go down in steps of 1 nanojoule or 2 nanojoule till you reach the level where the dissection becomes smoother and the bubble layer is smooth. But don't be too aggressive in reducing the energy, because we don't want to enter a point where you start getting black spots. The moment you see that there's a black spot, do not continue with the surgery and just increase the energy by 4 nanojoules, because we want to play safe. We can still manage the OBLs, but we don't want to get into the trap of dark spots. And this way, you can optimize energy for every step. So you can optimize the energy for the entry cut, you can optimize energy for the ring cut, you can optimize the posterior lenticule and the anterior lenticule energy. Of course, there be variables. Small variations can happen from machine to machine in the GBT score. The variations can happen with the corneal tissue, age, and refraction. And of course, the surgeon skills and the perfection of docking. So ultimately, what are we looking at when we are optimizing the energies? We are looking at a point where lenticule can be separated and removed with minimal separation force with the lowest energy possible. We don't want any black spots or any tear in any part of the lenticule. And ideally, in most of the cases, the same energy setting applies to all the patients. Unless and until you are dealing with a high number where you might need to fine tune your energy according to the patient reports. And this is what we are looking at, something like this when you have a beautifully optimized energies. Thank you.
Thank you. Just to add on to that, two things. Actually, an isolated dark spot that you get has got nothing to do with the energy, because that's actually a dry area where the penetration has not happened. These isolated dark spots means only that the energy was not present at that, because if the rest of it
people, multiple things, and you have to ask your patient what they're looking for and what they're expecting for the refractive surgery. So all my colleagues have gone into this. I'm not going to go into what is the modern day refractive surgery, but we have to understand our machine, our techniques very well without comparing it with one technology to another. And this is what Elita Silk has to offer us. And what I love the most about this machine is the spot spacing. And that's what I'm going to focus on, the spots and the shape. The spots are next to each other. They are placed 1 micron next to each other, and they are as small as 1 microns. So traditionally, when it comes to refractive surgery, you identify the anterior and posterior plane. That's what we do. And then you go ahead and dissect the anterior and the posterior plane, as we will, like a wiper movement. You dissect the anterior part and then the posterior part. You can see how easy it is in silk surgery to dissect it and remove the lenticule. And that is what we traditionally do. Now, what silk has is, it's the minimal spot separation. The spots are next to each other. So technically, there are no tissue bridges, and that's what gives an advantage of a smooth dissection. And that because there are no tissue bridges, because you don't have to dissect, it's minimal activation of keratocytes, and that's why you get a good optimal visual outcome in our patients. Now, because the spots are next to each other and because there are no tissue bridges, I will come to my disclaimer at the end of the slides, but what we have been aiming to do is, we try to dissect it as minimal as possible, and we just identify the anterior and the posterior plane. You have to be little 45 degrees up and 45 degrees down to identify the planes correctly, and we just try to swipe it once. You can see how easy it's become, I was trying to do a wiper movement quite a lot, and here now I'm just doing one swipe technique in the anterior plane, one swipe technique in the posterior plane, because the spots are next to each other. You need minimal dissection, and you remove the lenticule. So minimal your dissection, minimal activation of those myofibroblasts, and that's when you give good quality of vision on day one, and that's possible because of the spots next to each other. And this is what I was trying to say, that minimal manipulation, a wow vision on day one. Sometimes if the manipulation is more, that's when you not so wow vision. So you just have to refine on your energies and get to the spot where we are. And with further refination, and because of the benefits of the low energy and the spots separation 1 micron, we are trying to attempt something which is the peel or the one swipe technique, where we are just trying to grasp the lenticule, and then we are trying to dissect it and swipe completely in both the directions in the planes, and kind of a perpendicular movement like a rhexis, and that's what we aim to do, and we call it the pressure exerted extraction of lenticule. You identify the anterior and posterior plane, you grasp the lenticule, and just do like a rhexis. You can see how easy it is. You go on one side, finish 0 to 180, 90 degree, and go to the other side and remove it. That's when what you can do with 1 micron spacing and spots next to each other. Now, as Rahil mentioned, if you further optimize the energies, this is what you land up in. Now, I just, separate the anterior and the posterior plane. I grasp the lenticule, and I just push. I don't even do a rhexis. I just push and pull. It's just like your femtosecond rhexis. It's like your catalyst. Why do you do your femtosecond rhexis? When you have a femtosecond rhexis, you just go inside, take a forceps, just grab the rhexis in the center and bring it out. That's what something you can do with one spot, 1 microns difference, and just push, pull like a femtosecond rhexis, and that's when what you have to achieve when you have it. And when you have minimal manipulation, day one, the cornea is clear. You can see the retroillumination picture. It's the surface interface is smooth. There is the objective scatter index is 0.8, which is quite good. And there is minimal activation of keratocyte, and this is how you see the granularity. It's very smooth. That's what gives your patient day one outcomes. And of course, Dr. Shetty has mentioned this. I'm not going to go into this. Now, what are the other benefits or other advantages of Elita Silk? Now, when you have a lot of patients who have high astigmatism, -4, -4.5, or even higher, you always aim that, let's do a topo-guided LASIK, or let's do a wavefront-guided LASIK, because this patient has higher cylindrical power. I want to take care of the aberrations. Now, in silk, the advantage here is that we have a cyclotorsional movement control. If you have marked your 0 and 180 degree, you can actually manually cyclorotate the surgery or the laser pattern. And I'll just fast forward the video a little bit. You can see I can manually center it in the pupil in the Purkinje images, and then I will just cyclorotate it by 10 to 12 degrees so that it's in the right plane, and that's how the cylindrical power error corrections are much better. It reduces the risk of residual astigmatism of these patients. And the patient I saw, the pre-op was minus 4.5. Post-operatively, this is what you can see the day 1 ARR was. Then the patient was reading uniocularly 2010 and 2016 and binocularly 2010 on day 1. We have taken this study further, and we have 90 eyes now operated with 2 or 2.5 diopter of astigmatism and more. And we compared it with LASIK surgeries, and then you can see that at 1 month post-operatively, 100% patients were achieving 20/20 or better. The coefficient of determination, which is the R-square, was 0.995, which is also superior. It showed no change in, basically it was 20/20, but 41% of the patients showed gain in line, and also the residual astigmatism was much better. So because of the cyclotorsion control, you can actually go ahead and attempt doing a higher cylindrical correction in this patient with much superior outcomes on 1 month or better. Now, everybody's been talking about the biconvex shaped lenticle, and Rahil did show this video, but we wanted to prove the benefits of the biconvex shaped lenticle. So we did some ray tracing work and constructed what the biconvex shaped lenticle is doing. And one of the advantage what we saw was in low myopes. The low myopia correction, which is 2.5 diopters or lesser, was much better here. 59% patients at 2016 on 1 month. And you can see 56% of the patients gained 1 line or better in lower myopes, which you'll probably not attempt with a lenticle surgery. But here, because of the biconvex shaped lenticle, grasping or dissecting the lenticle is much better, and that's how the outcomes are good. Rushad has already explained the aberration, so I'll not go into details of it, but our results have been similar, and this is work which is recently published along with Hong, who was one of the masterminds behind the technologies. But to talk about the depth of focus, how the biconvex shaped lenticle helps, what we did was we compared the near, the intermediate, and the distance vision with an E-metrope. E-metrope is something which are the patients who never had any refractive error. And what we can see is the post-surgery outcomes in terms of depth of focus or depth of field of a post-silk eye was as good as a healthy individual. So that means post-surgery, you are not losing any depth of focus, but the quality and quantity of vision of these patients is much better. Now, everybody, including myself, we don't want to age, but as we age, our eyes also age. And then comes the question of presbyopia and refractive surgery. So again, this is not a presbyopic refractive error correction, but because of the biconvex shape of the lenticle, and as Rushad mentioned, the curvatures are being maintained quite well. The post-silk presbyopias, they needed less accommodation to see intermediate and near compared to that of a patient who underwent LASIK. So because of the shape of the lenticle, the depth of field, the depth of focus, and the accommodation maintained was also quite better in these patients compared to other. There's always been a debate in comparison to LASIK whether there is a reduction in biomechanics or the corneal strength post-surgery or not. So we did compare this results of SILK, which was done at 110 microns, along with LASIK and SMILE, which was done in 100 and 150 microns. What we see is that there is a lesser drop in biomechanics in SILK compared to that of LASIK and SMILE being performed as well. So it is actually the biconvex shaped lenticle is helping us maintain the biomechanics and the strength of this as well, and that is because when you have a biconvex shaped lenticle, the collapse of the collagen fibers are much lesser, and the disruption of the collagen fiber is much lesser here compared to that of a LASIK patient or any other patient. So this is what you see, that the collapse is much lesser here. So to conclude, yes, it does have a low energy laser. The spot size and distance is also giving us a benefit to have a minimal dissection or no dissection at all. It is having minimal collagen disturbance or minimal Bowman's disruption, and that's why with laser optimization, we are able to get post-op wow vision for these patients. So the entire work and technique, what I presented here, is because of the support and the wonderful technology J&J has developed, but the data, outcomes, and the techniques are our own clinical experience and judgment. Of course, we do want to share our experience and encourage fellow colleagues to explore and do the similar techniques and give wow outcomes to your patients as well. So thank you.
Okay, thanks for the Puja. I have only one question. In terms of the peeling techniques, so it doesn't matter if you go inside the anterior part or posterior part, right? So which you feel more comfortable to enter the posterior layer first or the anterior?
So I think the way the shape of the lenticule is, if your instrumentation for entering or identifying the plane is not proper, like 45 degrees up or down, you kind of go into the posterior plane first. So you have to be mindful when you are identifying the plane that you go 45 degrees up, so you are in the anterior plane, and you go 45 degrees down, so you are in the posterior plane. That ways you find out that the plane identification and dissection is appropriate, and you don't go into posterior first.
So his question was, you prefer to go into the anterior plane first for your peel technique?
Peel technique, you have to grasp both the planes. So
Yeah,
you
I
dissect
understand.
the
So
anterior first, then the posterior,
anterior
and then
first,
grasp.
that's what he was
Yeah,
asking.
yeah.
Anterior first.
Yeah,
thank
sorry.
you.
Yeah, thank you.
We go on to the last speaker for this session. Again, a great prolific surgeon, really high-end surgeon, I would say. Dr. Nitin Dedia from the OJAS Eye Hospital, that he'll be talking about his lenticule peel technique for better outcomes. He has been among the early adapters for the silk technology in India.
Very good afternoon. So today I'll be sharing with you some of the peeling techniques which we've been following, and I think here it's not. So you'll see here what we call as the lenticulorhexis, and here you can start peeling right from the number one position, that is in a clockwise manner, and you go all around, and then you just peel off the lenticule. So for this, again, you need good energy optimization, and of course, like you have to have it done in a very controlled manner. So yeah, you can you just, I cannot move my slides here. So here we are going with the forceps, and we go in the clockwise way, and you have to control the forceps very well, and so the main aim is to get good quality of vision and good recovery of vision, and for that very same reason, we have tried the different ways of how to do minimum dissection and to just peel the lenticule. So. Sorry for the interruption. So here we have gone all around and then peeled out the lenticule. This is what we call as lenticulorhexis, And in this, again, you have to do it in a very controlled manner where the forceps goes in and you slowly control the movement of your hand and you just keep peeling out this lenticule. Again, it will be important that your energy optimization should be very good. The better the optimization, the easier is it to just do this rhexis. And with this simple movement, you are able to remove the lenticule very easily. And the important thing is that this lenticule comes out very, very easily without tearing. So you do not have any tags when you do this. And even if you apply a little more pull, it is easy enough to remove it. The other way of doing it is what we call as hemi-lenticular circulorhexis, where you go from one end first, and then you go on the opposite side, and then you remove the lenticule. So again here, you apply pressure. First you just separate out the anterior, go above the lenticule a little, then again dissect out a little posteriorly. And once you are getting the plane, just go ahead and go from one side. And after going about 2 clock hours or 3 clock hours, then you switch over. You could either change your hand or you could go just with the same hand, you go on the other side and you peel it out from the other end, and then you can complete the rhexis. So this would depend again upon how much pressure you need to apply whenever you are doing it. And again, this would be related to the optimization of the energy. Then we have the push and the pull technique, where you just push the lenticule forward and you create a plane all across, and then you go on either side, first on one side, then the other, and then you can just peel out the lenticule. Again, this also becomes more easy and it's faster because you are just separating the anterior and the posterior part of and you get into the right plane. And once you are in the right plane, you just push the lenticule forward and it comes off quite easily. And then you go on either side and you can easily complete the rhexis. Depending upon the amount of resistance you feel, you can go from whichever end you find it is easier to just complete the rhexis. You can see how it just comes off very easily. So the idea is to do minimum amount of dissection so that you get faster recovery and there is minimum amount of disruption or reduction in the corneal aberrations, and you can get the wow effect for the patient. Also, one other technique what now I feel is more easier for the people who are just beginning to do this procedure and who find it, who do not want to do a complete dissection. In that case, what you do is just do a posterior dissection, and if you find, and normally posteriorly, the dissection is always tougher than the anterior. So once you have completed the posterior dissection, then it becomes very, very easy to just do a rhexis and just peel out the lenticule. So this is also one of the easier ways of removing the lenticule, and it comes out very easily. So our aim of doing all these different techniques is just that without much of dissection, you are able to peel out this lenticule and you can get that wow effect for the patient in the next day. Thank you.
Thank you very much. Any comments, Ajay or anybody? Can I have the panelist, Raghav, here? I think Rashad is not here. Yeah.
I have a question. So you have been doing it regularly, because what I feel, aren't there more chances of tearing of the lenticule and maybe retained lenticule at pieces?
So I have never, the best part about silk is I've never had a tear of the lenticule, because the way this lenticule, the spot size is, you are able to pull the lenticule very easily without tearing. It may not be very easy always to pull it out, but definitely if you are maneuvering your forceps, if not on one side, if it's causing more resistance on one side, you can go on the other side and you can pull it out, or you can just push it. So either you pull or you push, just like when you are doing your capsulorhexis, we have the shear forces, or you can just turn it and then pull it. But I've never seen tearing. Also, it may not be easy at all times to just peel out this, and you may have to do some dissection. So that is where you need to optimize your equipment, your energy levels, and at the least energy level, if you are getting the least amount of OBL, it makes it easier to peel it out. But as I said, the last case, what I showed, you need not do a full peeling. You can just do a posterior dissection, which is a little tougher, and then you are able to peel out the anterior part very easily.
Thank you. Can we
make question? One of a single question to chairpersons, both of this Chaukai and Mahipal, because once we dock, that the image is not a real time. So during that time, if patients move, it is not visible, and it's always a 16 seconds has passed till you come to know that patient has moved.
You're right. You're right. This is one of the drawbacks, because there's only that small hole through which you can see as to what exactly. But yes, if the patient has moved, you rarely end up in a surprise. Actually, the dock is pretty hard, so it rarely happens. But yes, it has happened. Even at the entry cut, if the patient has moved, then you have to take a call at that particular time. But it rarely happens.
Probably Urvija will be going to show one of the two videos on this. Thank you.
With that, I think we go on to the other session. I need to also leave, and Harpreet. And yeah, come. So these are a couple of videos. If you can just, we got the session late, but if you could just run through faster. Harpreet, then Raghav, Urvija, and Ashish.
Warm wishes. I am Dr. Harpreet Singh. I'm here to represent a group of 6 surgeons from Ludhiana city of Punjab. We are the new kids on the block, and we are doing it for last 5 to 6 months.
Yes, good.
And
Post one.
so let me, it has been a roller coaster ride for us. To start with, I would start on the positive note. We have found that tissue separation with Elita, as has been emphasized by other speakers also, is very smooth and easy. You can see how easy this newbie surgeon is taking out a flap. It is butter smooth, very easy. But once you have followed the procedure correctly, only then it is smooth. For the first 50 eyes that we have done, I would like to share the data briefly. I would like to divide them in 2 groups, first 24 eyes and next 26 eyes. In first 24 set of the eyes, we found that only 42% patients had 6x6 vision on day 1. But in the second set of patients, that's next 26 patients, we had 88% of the patients with 6x6 vision on day 1. There's a small table where I would like to tell you about the entry wound tears that happened in first 24 eyes. 50% of the patients had entry wound tears in first 24 eyes, but in the next set of patients, only 1 had an entry wound tear. Interface debris, 8 patients out of 24 in the first set, and next 26 eyes, only 1. So there were lint and metallic debris which was gathering. We changed the instruments, made the OT lint-free, and things improved. Of importance is the lenticule remnants. Lenticule remnants were 0 in first 24 eyes when all 6 were in the learning phase, and they remained 0 in the next phase also. That tells a lot about the kind of tissue separation that the machine does. So this was a typical day 1 picture, which you have an entry wound which is ragged, inflamed. You have debris in the interface, inflammation all around. This is a typical day 1 eye in the second set of patients. Clean corneas, entry wound hardly visible, and 6x6 on day 1. Regarding the managing docking, docking was, initially we were like very scared. We used to keep high energy, used to do very hard docking. Hard docking got us into trouble with a lot of subconjunctival hemorrhages, and even the pupil got eccentric. So getting the centration was difficult. So we brought it down to 50 or 60. The vertical height was less than 50 in most of the cases that we are doing now. So less of tomato eyes nowadays, and the pupil becomes less eccentric. In this video, I would like to show you where initially the vertical height is being taken to 70 or 80, but then we are keeping on the lower half of the grain. So that keeps the pupil right in the center and helps you in better centration. So you can see in this video, the pupil is dead in the center. It has not moved. If you keep it 70 or something, it will definitely move supero-nasally. This is one thing which happened in our patient, a black island, and very difficult situation we had with this patient, and very difficult result. But to avoid it is very simple. Keep the ocular surface clean. We always try to keep the lashes tucked away nicely into the drape, and we always clean the ocular surface nicely, and we make sure the extra water has been taken away from the eye by using a dry sponge in the periphery. Don't touch the cornea with a dry sponge. And even after docking, we don't hesitate. If we find that cornea has gone dry, we try to wet the cornea even after putting the suction ring. So that is before the docking. You can see in this video, the surgeon feels that the cornea has gone dry and there are chances of developing a dark spot. So we go ahead, use a wipe, although this is not recommended by the company, but we are doing it routinely and getting credible results. One good friend of ours has been this little instrument called LIMS. So for the newbie surgeons, I would recommend LIMS should be used to give counter-traction. It helps you in better dissection initially. Later on, you may or may not use it. And one thing which has been emphasized over again and again is the energy optimization. Initially, we thought higher energy would give us better dissection, but it is just the reverse. You must quickly get your energy optimized so that you get a good minimal inflammation and a good result on day 1. And one thing we are still struggling with is the centration. It's a manual centration that we do, manual marking and manual centration. And my suggestion is that preoperative scanning with a good equipment and with automated centration is the need of the hour. So our key takeaways are proper tools and training are essential for good results. Optimizing energy and soft docking aids in smoother surgeries and better outcomes. Mastering dissection is easier with Alita for newbie surgeons. Increasing intracone illumination enhances interface visibility. Meticulous cleaning of the ocular surface is essential, and good practice in refractive surgery is definitely rewarding. Thank you so much.
Conjunctival hemorrhage. I think that's very important. So you're talking about soft ducting with the centric ducting. So how do we try to our best to avoid subconjunctival hemorrhage? I think that's also important for the post-day 1.
Yeah. So first of all, we are using brimonidine as a routine in our silk patients. And secondly, it has been our experience that if we dock very hard, the vertical height is around 80 to 90, definitely subconjunctival hemorrhages have been more, and they have been more profound also. As the vertical height has been brought down to 40, 50, lesser subconjunctival hemorrhages.
I think I would agree with sir that because it's a scleral suction and docking, there is bound to be some subconjunctival hemorrhage. That there is pros and cons of it. The pros is it's a good dock, a hard dock, so you have minimal chances of suction loss. But for the subconjunctival hemorrhage, a soft dock or a pre-op of brimonidine works very well. So I think what you've been doing is quite good. And once we have started doing these two techniques, our subconjunctival hemorrhage is less than 1% in the patients. It does come, but it's less than 1%. Thank you, sir. And I would like to invite Dr. Raghav, who is a consultant at Center for Sight, to share his video on perfecting silk.
Okay, so in the paucity of time, I'll quickly just run through my 10 tips on perfecting silk. On the outset, thank you J&J for inviting me. I'll just give you a brief overview. For the past 5 years, we've been using silk. We are silk users, so we have had a number of experiences that have allowed us to increase the visual potential of the patient, give the patient a better outcome and a faster outcome. So first and foremost, the perfect dock. So we know that the PI for this is a 2-piece PI as of now. So 2-piece PI with a flat interface, the perfect dock is very, very important. So we need to have the docking to be exactly parallel. So the grabber of the PI has to go parallel to the ground. If it is not parallel, we are going to have a decentered dock. A decentered dock will lead to a decentered ablation or a decentered lenticule, which will cause a difference in aberration profile. So this is how we want it to be well centered. We want a good limbal show all around. And lastly, the first chance is your golden chance to dock. The second chance, once you go into the second dock, you are going to have some subconjunctival hemorrhage, some chemosis that can give you a pseudo suction. So try and attempt your dock in the very first time. So you see, this is the 10 millimeter zone. We want our applanation to go beyond this 10 millimeter. Once we are beyond this 10 millimeter zone, we know there's a good applanation. So now this is something which is totally our experience. This is not said by J&J, but yes, we feel that the vertical level, that once you have docked, you want to go into the upper level. So we were advised by the ASMs to go between 60 and 70, but we found the results were not that accurate. So in the last 5 years, now we know that if our patient is not 6'6" on day 1, we are surprised. But this was not the case 4 years back, because we were of course on much higher energies and the vertical levels were lower. So I'll just give you just a schematic to show what exactly is happening during docking. So it is a flat PI, and once we are going down, we are actually compressing the cornea. Let's imagine the cornea is 550 microns. So this is the cornea which is not applanated, and once you start applanating, if you are in the 60 to 70 zone, you are just compressing the cornea. But if you are in the 10 to 15 zone, the cornea is much more physiological, and the laser fires in a much more physiological cornea. Of course, a cornea is not like this. A cornea is much more tensile. So I would like to go ahead and change the sample to this. Imagine you have a rubber band ball. That's exactly how the cornea is. We have lots of collagen fibers that are interlocked, and if you pass a flat PI onto a prolate cornea, first of all, there will be flattening of the cornea, of course, and secondly, all the lamellae are under stress. So the laser passes through a stressed cornea. That is going to give you the hazy vision. That is why now we have started going to 10 to 15, and with that, the vision outcomes are just simply amazing. So it gave us an overnight change. Of course, I don't recommend that if you are at 60 to 70, come down to 10 directly. Go down slowly. If you're at 70, come to 65, then 60, then 55, and you see whether your visual outcomes are improving or not. And once they do, then you can have your sweet spot. So try and be in the early levels, but do it slowly. Next, marking the visual axis. Of course, this is the beauty of a flat PI. You can do a post-docking centration. So always mark the Purkinje image, and then once you have marked the Purkinje image, you can always center the lenticule after docking. That's the advantage of the flat PI. Now fourth, finding the perfect settings. This has been discussed many a time. So this is a case when about 2 years back when this was the energy setting, you can see that there is a central thick white band and you can see this OBL in the anterior between the stroma and the cap. I'll just pause it here 1 second. So you see this OBL, that's just a collection of the energy. That is a cue for you to decrease the energy. Once the energy is decreased, of course, finding that sweet spot is amazing. Once the energy has decreased to a certain level, giving you a decent amount of section. So the aim is to give that patient that wow, because the patient is coming to you expecting a 6x6 the next day. We can, of course, keep the energy higher and do a faster dissection, but the aim is to have a decent dissection and clear corneas. So find that perfect energy setting. We have, of course, come down from 70 now about 31. So these are the parameters which can be altered. You can change the posterior, the anterior, the ring, and the entry energy. The central white OBL band can be decreased by decreasing the ring energy. Keep that to a minimum. Of course, you can decrease the flat ad. You can decrease the cap thickness for higher myopia. That will give you very good results. So this is of course, Dr. Mahipal showed how the energies have gone from 60 to 65 down to 30 and 31. It is giving us very beautiful results. Check the GBT, the glass burn threshold, that will be told to you by your ASM. Every machine is unique, could have a different GBT, will have a different GBT. Your GBT is a starting point. Start your dissection from there. See how your corneas are, how your post-op results are, how the dissection is, and slowly decrease the energy by units of 2. Don't jump down immediately. Go down by units of 2 and see how the dissection is and how the corneas are playing out. Of course, avoiding dry spots while docking, very important to keep your corneas moistened. Don't let them dry, because drying is going to give you those isolated dark islands which will cause difficulty. This is a patient that had severe mebum secretions, and these mebum secretions can cause these dark spots, but they are managed. They are managed very well. The trick is to slowly start encroaching onto the island. Don't rush into it. Try and start slowly encroaching into the center, and once the anterior plane is done, half the baton is won. Then go into the posterior and slowly encroach and make the island smaller. Making this island smaller is going to reduce that black spot and will give you amazing results. Don't try the peel technique here. Try and go slowly, and once you have dissected the anterior and the posterior plane, that is when the lenticule can come out. I'll just quickly go and show how the lenticule was removed. Of course, there is a struggle, but you have to go slowly, and like I said, decrease the island slowly. There's a lenticule in toto. Of course, a little trick that we use is to actually just rub the center of the cornea after docking, so that you can disperse some OBL so the patient can have a clear view of the microscope light, and it will give you better cooperation. Surgically, keep your cornea and your instruments moistened. If your instruments are moistened, there will be lesser friction inside the eye. Spend lesser time in the cornea. I was taught during my post-graduation, 1 minute inside the cornea is 1 week of edema. So try and keep as little time inside the cornea as possible. That is where the peel technique really helps you. Take out the lenticule within 60 seconds, you will have good results. Bowman ironing, of course, is very important. At the end of the procedure, we tend to hydrate, and then we do a good Bowman's ironing. And lastly, adjust your nomogram. Circle back, see your results. If you feel your results are hyperopic or myopic, change the nomogram given to you. You can adjust, see your patient, see your results, and adjust the nomogram. These are a half-decade outcome which have been discussed already, and this is, of course, what is on the horizon. Thank you.
Thank you, Raghav. The 10 tips for perfecting silk were perfect, and I think for the sake of time, we'll move on to the next video from Dr. Urvija, who hails from Indore, and she's going to talk about learning curve from beginner to expert. I would like the last speaker, Dr. Ashish Bansal, also to be ready, and please try to stick to time, sir, because we have to hand over the session. Yes, sir. We were given the session late by half an hour, so I think that's the previous session which is running late. Dr. Ashish, your video is ready, then we can Probably you can start first, and then we'll go to Dr. Urvija. He's going to be presenting about importance and techniques of visual access and centration marking for better visual outcomes. And I'm sure, sir, you have wonderful tips, but if there are slides and if you can avoid the repeat.
Definitely, I will stick to the, and
Thank
we
you.
already late, I know that. So good afternoon. As we all know, like we are being, kindly start. It is ready but not showing there. So as we have discussed, like it is very important in the silk, as multiple speakers and our fellow colleagues, they have discussed, like one thing is very important, like it is the need of the hour that we get an automated something which is focusing on the centration.
Can we have the slides, please, on the screen?
Here it is ready, kindly play this. So coming on to the, as we know, there is some difference from the excimer laser, like there is no active tracking, no cyclotorsion compensation. And these are the various studies which are based on the lenticule extraction, which have highlighted the role of centration and in the better visual outcomes by Liu et al., Zhang et al., where they have showed that if the centration is not proper and the visual axis marking is not proper, then it could lead to the visual outcomes are not good. There is more of higher order aberrations, comma aberrations, and the post-operative visual acuity is not good. So coming on to this, one of the important factor which I have observed, like as we have seen, like the most of our, we are used to using the intralace platform of the J&J, and there is a slight difference between the intralace and the Elita platform is that in the intralace, the docking because of the bigger cone and no nasal obstruction due to the hump in the Elita, there is a more straight applanation, whereas in Elita we need to, there is more chances of nasal obstruction, so we need to tilt the head, and this lead to more slightly decentered applanation in this machine, and though this also further increases the importance of better centration. So these are few of the points which are important, like for better centration we can fix like the pupillary axis, the visual axis. The ideal point to be marked is the corneal vertex, and these are the various techniques for marking, like the 3-point bubble marker. Then what I do here in my center is that we mark horizontal 0 and 180 degree on the slit lamp, and further the further marking is done on the during the surgery. So coming on to the technique, sorry, it is not playing. Sorry. वीडियो एडिड है, फोल्डर में एडिड है, फोल्डर में ऐड। So what we do, like during the, it is not coming here. Yeah. Sorry about that. So during the technique, we do the centration marking while the patient is lying on the slit, earlier on the excimer laser. I will show you again. So this is the simple instrument which we use during the silk surgery. This is the lifter for the lenticule, and this while patient is lying on the excimer laser, we fix and mark the centration with the help of this instrument. And then while aligning the surgery, we can align this centration mark with the center of this during the surgery. And you can see it is very well coming off. And similarly, these are again in the so this technique, what I have observed, it has a lot of benefits, and because it is very simple to do, and just like we have in J&J suite, so the patient is just before the surgery, we can mark the centration of the pupil, and just after. So I would say like the benefit of this technique is like it is very simple and very accurate, and just prior to the surgery, a surgeon can do this technique himself, because many surgeons, they used to tell that when we do the marking on the slit lamp, and sometimes when they see the patient in the OR, the mark is not there. So when we do it there and then, it is very simple, and there is no extra instrumentation is required. And as it is very convenient for the patient also, while doing the surgery, the patient can very easily focus into the excimer laser, and the patient is fixing easily rather than while doing on the slit lamp. And the mark, as you have seen, is very, very fine. Like in the center mark also, it is not interrupting into the visual axis anywhere into the femtolaser dissection also, so it is not compromising on the results. So thank you. I just wanted to highlight this technique. Yeah.
Thank you, Dr. Ashish. Thanks. Dr. Vijay, can you please have your slides? Thanks. So yes, it's a very good advantage that we have with the LITA, where we can have visual axis centered lenticules, which give us very good post-op outcomes.
Thank you.
Hello. So we have been seeing that Silk is giving us very wonderful results. So here is this is a video with all my cases from past 2 years, where I have concluded, and there are some tips and pearls for all the new beginners, for all the new learners, as people are shifting more towards the lenticule surgery. This will help them to get the lenticule procedure faster, learn faster. There is no audio. Volume, please.
Silk, smooth incision lenticule keratomiliosis. It's an advanced lenticule extraction procedure with a fast learning curve. With our initial cases, we learned that marking the visual axis helped in better cyclotorsion, and adjusting to the pupillary center was important for best visual outcomes. Sometimes while docking, eyes may be decentered, and repeated docking leaves an oily film on the PI. This oily film can hamper the laser firing, especially at deeper planes as required in lenticule making. Thus, using a new PI at such times can be really helpful. This was one such case of uncut lenticule when, on retrospecting, we observed there were multiple docking attempts made. Fluctuation in temperature was also noted. This was planned for a PRK after complete healing and stability of refraction. While in your learning curve, keeping the entry wound to about 4 to 4.5 mm initially can ease the dissection maneuver and prevent tearing of the edges of the wound. This width can gradually be brought down to 3 mm once we are comfortable with the surgery. Similarly, entry to edge extension can also be increased by a few millimeters to give more space while finding the anterior and the posterior planes. Also, sometimes you may find black spots during femtosecond laser firing, this leading to difficult dissection. This may be due to high myopia, where laser has to penetrate deeper and may need higher energy, or due to dust over the internal optics that needs cleaning in proper intervals. Finding the right plane is a challenge in initial cases, and simple steps can ease that. Like, while making the anterior pocket, tent up a little and dissect till midway. For posterior plane, dip in a little and start from extreme right and cross the midline. If you feel the resistance while crossing the midline, you're in the right plane. The other way to determine the plane is by making cut edge of the lenticule as a guide. This mark is clearly visible on top of the dissector when entering the posterior plane, whereas this cut edge mark is not visible if entering the anterior plane because dissector is above it and covering it. We can also use opaque bubble layer to our advantage. Visibility of the dissector is more when in the anterior plane, whereas it reduces when in the posterior plane due to a layer of OBL over it, thereby reaffirming which plane we are in. Even when the planar dissection is complete, never force pull the lenticule in case resistance is felt. It may leave uneven edges or tags behind. Removing inner circular motion will give a gentle force and prevent uneven tags and edges. Sometimes you may find incomplete laser cuts due to vacuum loss or decentered eye. This was one such case where after complete laser firing, eye was found decentered and rolled upwards. We could see that the anterior plane dissection is also asymmetric and shifted downwards, and the entry cut was superficial and not formed. This situation needs to be dealt very patiently and was planned next day for a femto flap at 90 microns depth to avoid the plane of silk dissection. Flap lifting was done very gently as to not disturb the stroma at all. An excimer laser ablation was accomplished for a good post-operative visual recovery. This is one more case of an incomplete entry cut formation, but here the anterior plane dissection appeared complete and well centered. So we tried to create a manual entry cut with the help of a sideport knife. After creating the entry cut, anterior and posterior plane pockets were created. And the lenticule could be dissected out very smoothly. Few minor things make all this process far easier, like using a good holding forceps for better dissection, keeping the surface moist for more clarity, and a good microscope for increased depth of focus and a good visibility.
Thank you, Ruja. We cannot have any more
Thank you very
discussion
much.
as we already ran late. Please, apologies for the next session. We now hand over the dais.